Madhvi Natarajan and I'm based in the UK. So the aim of today's talk is to learn how to take a focused history and assess a stone patient, to recognise patients with stones, to differentiate non-urgent management from urgent management for stone cases, and to understand the different variety of options available for stone patients, and then to understand the different types of stones that may occur. So urinary tract stones, or urolithiasis, is quite common the world over, and as you can see from this map, it is more common in India, affecting almost 9 to 10% of people in this report, whereas in Europe it affects about 5 to 10% of people. A few papers have talked about the epidemiology of stone disease in India. It's approximated that about 12% of the total population are affected by stones, but this is more prominent in northern India than it is in southern India. There is, in some papers, a kidney stone belt described, which is affecting specific areas of India, including Maharashtra, Gujarat, Rajasthan, and more. Some of the reasons proposed for the difference in the stone rates in these areas compared to other parts of India include things relating to the temperature and to diet. So as with any medical school exam, we will often be asked the etiology of stones, and this can broadly be divided into 4 subsections. There can be stones not related to infection, infection-related stones, genetic-related stones, and drug-related stones. This is quite broad, and as you can see in this table, which is actually from the EAU guidelines, they've also subdivided each of those 4 sections into the actual type of stone that is produced. Now, why do people form stones? As we discussed on the previous slide, there are numerous reasons why people may fall into the category of stone former. However, there are specific risk factors, some of which are modifiable, which contribute to stone risk. These include having a family history of stone formation. Additionally, if you have had a stone in your life, approximately 26% will have another stone within 5 years. Only 50% will survive their entire life having had a stone with only 1 recurrence. Other contributing factors include diet. Protein-rich diet, meaning animal proteins, is a significant contributor. Also being overweight or having a body mass index of greater than 32. Furthermore, those with recurrent UTI or with neurological conditions resulting in neurogenic bladder have a higher risk of stone formation. Now, this is quite a detailed table, and in fact, this is not even the full extent of the detail within the EAU guidance about risk factors for stone formation. But if you are interested, or if you want to know more detail, the EAU guidance has a number of very well laid out tables from which you can learn about the risk factors for stone formation. Now, the symptoms from stones are really extremely far-ranging. They start from no symptoms whatsoever. We do often find that stones are diagnosed simply from an incidental finding on some form of imaging that the patient will have had for a different reason. Otherwise, ureteric colic, or renal colic as it is more commonly called, where the patient may present to A&E or to their GP with pain over their flank or with a mild AKI, or the worst case scenario, which is where the patient presents with an obstructing stone, potentially causing infection, resulting in a severe AKI, and if there is infection involved as well, a systemic inflammatory response. Now, the term renal colic is a slightly odd description as it is inaccurate. Really, we get colic when the stone is located within the ureter. As you can see on this picture, I've highlighted a renal stone, which is in the left kidney, a PUJ stone, which is in the right kidney up at the top, and then a VUJ stone down at the bottom of the left ureter. So the 2 ureteric stones, the PUJ stone and the VUJ stone, are the ones that would be causing ureteric colic. The one in the kidney, however, whilst it could be associated with infection, is unlikely to cause colicky pain, as it is sitting within a large space and not causing obstruction. Now, we see stones in a number of different environments, but the main reason a urologist would be involved is when a patient presents in an emergency to A&E with severe flank pain that is unremitting, often associated with nausea and vomiting. One of the key features of this type of ureteric colic is that the patient can't find a comfortable position and is constantly moving around. This may be associated with hematuria, which can, in some occasions, be visible hematuria. Some of the red flag symptoms that you need to think of as soon as you see a patient with any of these symptoms is: do they have any sign of infection in terms of white cell count, CRP, or urinalysis showing nitrites or leukocytes? Do they have a fever? Are there observations suggesting that they are unstable? Is there a severe AKI? And do they have a single kidney? Any of these features would make this patient an absolute emergency needing urgent investigation. So, assessment of these patients. This is exactly the same as assessment of any other patient that you would have in your clinic or that you would see in an A&E. So you start with history, move on to examination, and next comes investigations. And I would implore you, as you prepare for your exams and as you prepare to become junior doctors, it's wise to constantly follow this structure so that you don't falter. So first, history. The key features of the stone history are whether the patient themselves have had stones before, whether they've got family members that have had significant stone burden, whether the patient has any other medical conditions, and in particular we focus on Crohn's, inflammatory bowel disease, whether they've had bowel resections, and additionally whether they have other neurological conditions including MS. Following that, you would perform a full examination of the abdomen, assessing for any concerning features including flank tenderness, and ideally you would do observations as well to assess for any signs of infection. So now we'll move on to investigations, and just as I've categorised here, I would urge you to try to categorise the way you describe your investigations, just so that it makes more sense in your head, and so when you present it during an exam, you don't forget key details. The three categories I use are bedside, blood tests, and imaging. Now for stones, I think it's essential that bedside tests includes observations and a urinalysis. The bedside ultrasound is a nice add-on if you know how to do it, and if you have the resources, it can help identify hydronephrosis early. But really, what we need to know are the observations to know whether there's any sign of a systemic inflammatory response, and urinalysis to know whether there's nitrites and leukocytes in the urine suggestive of infection. Blood tests. So routine blood tests would include white cells, CRP, and renal function here. These are the same ones that you need for investigation of a stone. Main reason that we're doing the renal function is to look for AKI, and the main reason we're doing white cells and CRP is to assess for any sign of infection. The uric acid and bone profile tests are both aimed at trying to understand what type of stone the patient may have formed. Now, in terms of imaging, I've put three forms of imaging down there, and I've highlighted CT-KUB because that really is the mainstay of imaging that we use to investigate ureteric or renal stones. Abdominal X-ray can be useful, but is mainly used as a follow-up test here as you're monitoring the patient's stones in clinic. Ultrasound KUB, as I said before, can be very useful to identify hydronephrosis. But in an emergency context, the main reason we would use it would be if there's a special circumstance, such as a pregnant woman who needs investigation for a suspected stone, but who cannot have X-ray or CT. Now, I just thought I'd go into a bit more detail about how we choose the type of imaging. Over the years, these three types of imaging have all been trialled and compared. What we found in this paper by Roy is that ultrasound KUB can be useful for identifying PUJ and VUJ stones, or indeed intrarenal stones and hydronephrosis, but its sensitivity is only about 45% for ureteric and renal stones. The sensitivity and specificity of X-ray KUB is much lower, between 44 and 77% overall. The CT KUB, however, which often is low dose, has a sensitivity of 93.1% and a specificity of 96.6%, which really makes it much more valuable as a single test for the patient and to guide further treatment. Now, why is X-ray less useful in imaging for stones? Essentially, it's based on how radio-opaque the stones are. Now, the majority of stones are calcium oxalate and calcium phosphate stones, and these ones are radio-opaque. However, if they're very small, it's sometimes difficult to identify exactly their location based on just an X-ray, as you only have a 2D image. CT-KUB, however, is a lot more precise and allows you to have both axial, coronal, and also sagittal views, which allows you to get a 3D impression of where the stone is within the person. The other reason X-ray is not useful in some situations is in uric acid stones, xanthine stones, and indinavir stones, which is a drug, a HIV medication. CT-KUB can actually pick up on uric acid stones and xanthine stones, although not necessarily on drug stones. Now, if you try to search on the internet about how to manage stones, you'll find lots and lots of different flowcharts and guidelines, and these ones are from the EAU guidelines. They're quite useful, but perhaps a little more detail than you need for your exams. However, as you can see, just broadly, they've divided the management of stones into kidney stone, lower pole stone, ureteric stone, and they've divided the ureter into proximal and distal. Additionally, we assess the size of the stone and also how hard the stone is based on the Hounsfield units on radiological imaging. Now, I would divide the management plan really into immediate, early, and late. The previous slide talking about where the stone is, etc., is more focused on early management, the surgical options, and how you decide what to do and for what reason. But what we really should think about in more detail is immediate management, and that's what I want you to take away from this talk. Immediate management for stones involves a full assessment of the patient, followed by providing adequate analgesia, stabilizing them, and making the decision about whether or not they need disobstruction. Just to go into a bit more detail about immediate management, there's really not very many things you need to consider, but these ones are the essential ones. Firstly, is the patient infected or are they not? Is there an AKI? Does the patient have adequate analgesia on board? And should I give them an alpha blocker? Now, I've drawn here the ladder that we use for pain management in ureteric stones. The first treatment is diclofenac suppositories, which is obviously different from the WHO pain ladder. We use diclofenac because it is the most effective painkiller against ureteric colic. Paracetamol is the next step up on the ladder, and finally you get to opioids. Opioids are generally not as useful because they actually paralyze the ureter, which can make ureteric colic worse and can make the chance of stone passage reduced. So we try to avoid opioids at all costs. However, in A&E, generally the first painkiller that patients are treated with is an opioid. So just be aware of that. But really, the thing to highlight is the section in red, which is if you suspect an infected, obstructed stone, this becomes an emergency and time is of the essence. So this slide is about managing the infected, obstructed stone. As with any other unwell patient, you would have to do the urgent assessment of the patient using the ABCDE approach, airways, breathing, circulation, etc. Next, you move on to investigations. Again, you can do the bedside, which would be urinalysis. You can do blood tests, which should include full blood count, Usinase, CRP, blood culture, and lactate. And then you move on to imaging, which would include a CT-KUB, ideally. The treatment would be initiated, and that should include intravenous fluids, intravenous antibiotics, and an urgent decision of how you're going to disobstruct the patient. The two options that we tend to have are stent insertion, which is a general anaesthetic operation to insert a plastic straw-like structure, which you can see in the picture on the left in green, sitting in the left ureter, which allows continuous passage of urine bypassing the stone through the stent. Or the other option is an emergency nephrostomy. The emergency nephrostomy tends to be used on patients who are even more unwell, who cannot perhaps tolerate a general anaesthetic. It's a needle straight into the kidney, into the collecting system, and then a tube is placed into the kidney to allow the urine and probably by this point pus to drain. Once the infection has drained away, the patient improves, and then this tube can be internalized. This is a very simple slide. I just wanted to highlight as well, if you do have a patient with an infected obstructing stone, escalate early. This is because the patient needs often numerous teams to be involved, and the earlier you escalate, the more you can delegate work or share work between you, and this will help ensure the best outcome for the patient. So now we can return to the patient who does not have an infected obstructed system but simply has a ureteric stone. One of the question marks about treatment for these patients, once you've managed them with analgesia, is of whether they should have alpha blockers or tamsulosin. This is known as medical expulsive therapy. There have been two significant studies that have been published, which it might be worth you reading. The first was the SUSPEND trial, which looked at just over 1,000 patients, randomizing them to having tamsulosin, which is an alpha blocker, having nifedipine, or having placebo. What they found in this study was that there was no difference between the three groups in terms of how likely it was that at 4 weeks they would need an operation to treat the stone. So on the basis of this, and on the basis of the cost of tamsulosin, it was felt from this study that they couldn't recommend that patients should have tamsulosin to help them pass their stones. However, a study in 2021 was a meta-analysis by Yu et al. That found that on subgroup analysis, medical expulsive therapy was indeed useful, but mainly for distal ureteric stones. So really, it needs to be something to consider and potentially something to discuss with a senior when you're working out what to send the patient home with. Now, as I alluded to on the previous slide, stones can sometimes pass on their own without any treatment, and this would fall into the category of conservative management. Medical management also would be helping the patient pass their stone with analgesia, medical expulsive treatment, but making sure that they monitor closely for infection and severe pain. Otherwise, there are non-surgical treatments, including shockwave lithotripsy, or ESWL. This is suitable for some patients if their stone is able to be seen on X-ray, and if they are not on blood thinners and they're not pregnant, they may be suitable to try this, which is high frequency ultrasound shockwaves that can break a stone down into smaller pieces, helping facilitate the patient to actually pass them in their urine. If conservative and medical management don't work, or if lithotripsy fails as well, the patient then needs to be considered for surgical treatment of the stones. There's numerous different ways of doing these operations, and we decide what type of operation specifically to do based on where the stone is, how hard the stone is, and the patient's other comorbidities. But broadly, you can divide the surgical options into ureteroscopy, which can be subdivided into rigid ureteroscopy for ureteric stones and flexible ureteroscopy for intrarenal stones. And then the other option is PCNL. PCNL would use a tract made directly into the kidney, same as you would do for a nephrostomy, to treat probably a larger stone within the kidney. Now, the next few slides are mainly talking about the different types of stones that occur. The most common are calcium-based stones. This is divided into calcium oxalate and calcium phosphate. Some of the findings on investigation would include high calcium levels in the urine. The management of this type of stone would include trying to reduce oxalate intake in the diet and also increasing fluid intake and reducing salt. Uric acid stones are much less common, affecting only 5 to 10% of people. They tend to be associated with low urinary pH and are caused by excess uric acid being excreted in the urine. These are associated generally with the person being overweight or having other metabolic conditions, including type 2 diabetes. And if you'll remember, uric acid stones are radiolucent on X-ray. Struvite stones, also known as triple phosphate or magnesium ammonium phosphate stones, are often related to chronic urinary tract infections. These are more common in patients who have an inability to empty their urinary system. This may be because of conditions such as MS or a spinal injury. They tend to form in alkaline urine and they can get very large. Finally, cystine stones are a much less common type of stone, affecting just approximately 1% of the population. This tends to be linked with a genetic disorder with cystine excretion, resulting in excess cystine excretion from the kidneys into the urine. The management still involves drinking plenty of water per day, but additionally the patients may be taking potassium citrate to reduce renal acidosis. And they need to be closely monitored by metabolic services within the hospital. So, thank you very much for listening to this whirlwind tour of stones. We've touched on a lot of the different areas, including general history taking, examination, investigations for stones, why you would choose different types of imaging, and how you would go about managing the patient in an immediate sense, and then how you would manage the stones in a longer term sense. There is a lot more detail to this topic of urology, and I recommend reading the guidelines if you can, as they're quite useful in helping you understand the differences between the different types of stones and the risk factors. Thank you very much for listening today. I'd be happy to take any questions now, or you can email me at the email address at the bottom of this slide. Thanks. Thank you very much for the opportunity to take part in this online teaching program. I'm going to cover some urological topics, and one of my presentations is about bladder outflow obstruction. My name is Madhvi Natarajan, and I'm a urology registrar in the UK. The aims from this talk are to understand how to take a history for lower urinary tract symptoms, to understand that BPH or BPE is a progressive condition, and to understand medical management of lower urinary tract symptoms as well as surgical approaches. To start, I will explain a little about the anatomy of benign prostatic hyperplasia or benign prostatic enlargement. In the UK, we're more commonly using the term BPE, as this is more a description of the effect of the anatomy on the actual symptoms. The prostate is located just inferior to the bladder. It is divided into two zones, that is the peripheral zone, where prostate cancer is more likely to occur, and the transition zone, which is in the centre of the prostate, as highlighted on this image. As men age, the transition zone tends to grow due to benign prostatic hyperplasia, and this can cause a compressive or obstructive effect on the urethra, resulting in obstructed urinary flow. Now, you've heard LUTS a few times already during this talk today. LUTS is the term we use to describe lower urinary tract symptoms. Male LUTS tend to be divided into storage LUTS, voiding, and post-micturition LUTS. These are grouped symptoms that describe the effect of the enlarging prostate on urinary flow. Bothersome LUTS occur in up to 30% of men over 65 years, and as you'll see on the slides coming, we do measure progress with low urinary tract symptoms, or BPE, with how bothered the patient is by them. The subdivisions of LUTS are voiding symptoms, storage symptoms, and post-micturition. Voiding symptoms include weak or intermittent urinary flow, straining, hesitancy, terminal dribbling, and the sensation of incomplete emptying. Storage symptoms are more in keeping with overactive aspects of lower urinary tract symptoms. These include urgency, frequency, nocturia, and incontinence. The post-micturition symptom that people are bothered by is post-micturition dribbling. Now, this slide is just for interest, as I found this study by Coyne and Sexton, which was known as the EpiLUTS study, looking at the prevalence of lower urinary tract symptoms in both males and females across the UK, Sweden, and the USA. Interestingly, the most bothersome LUTs identified during this study included weak stream, terminal dribbling, nocturia, incomplete emptying, and post-micturition dribble, and these caused more bother across both males and females. On this slide, this graph shows quite clearly that there is an increase in the prevalence of lower urinary tract symptoms with age. This was a study done in Australia that divided the lower urinary tract symptoms into frequency, nocturia, urgency, weak stream, intermittency, and incomplete emptying. Just looking at frequency, for instance, there was a prevalence of about 10% of this symptom in the subsection of 35 to 44-year-olds, but once you reach the section of 60 to 80-year-olds, this prevalence increased to almost 20%. As you will have gathered from the previous slides, lower urinary tract symptoms are clearly linked with benign prostatic hyperplasia for men. However, there seems to be a noticeable mismatch, as highlighted by this paper by Truman. In a survey of 1,500 men, 41% reported some degree of lower urinary tract symptoms that were moderately bothersome. However, only 18% had a diagnosis of BPH, suggesting a reluctance to present to health services with this problem. Just as I was preparing these slides, I searched for information about the prevalence of BPH and LUTs in India, and actually found quite limited information about this. There was a study by Hummer looking at an epidemiological survey of lower urinary tract symptoms in Asia and Australia, but otherwise I didn't find much about rates in the Indian population. This may be a nice project for one of you to do to actually understand better what the rates are amongst Indian populations. So just to go into a little bit more detail about how you might approach a patient who comes in with LUTs. As with any other patient, we have to start with basic history taking, including a review of the medication that the patients are taking. Furthermore, a past medical history to find out if they've had any specific issues that may explain some of the symptoms in the past. And then examination, including a digital rectal exam. We use the International Prostate Symptom Score to help guide reporting on lower urinary tract symptoms. This is quite useful as it is divided into the various subsections of symptoms that cause bother. These are incomplete emptying, frequency, intermittency, urgency, stream, straining, and nocturia, with a final quality of life question to ascertain how the patient would feel if they ended up with this situation for the rest of their lives. The score is out of 35, and then the quality of life score is quoted separately out of 6. In terms of understanding the scoring system further, we tend to look at the score out of 35 and categorise this. A score of 0 to 7 would suggest mild low urinary tract symptoms. Moderate symptoms would be highlighted by a score of 8 to 19. And if the person scores greater than 20, they would be considered to have severe lower urinary tract symptoms. Now, LUTs investigations are numerous and are carried out differently by each department. However, I would have said that these are the basics that should be done when a man presents to clinic with LUTs. First of all, you would do a urinalysis to assess for any sign of infection and also for any sign of blood in the urine. Ideally, they should complete a frequency volume chart so that you could understand what the frequency is like through the day and the night. Furthermore, a flow rate and post-void residual is extremely helpful in understanding what the actual stream is objectively like, as well as how well or how successfully the person empties their bladder. A PSA test is essential to know that there are no other contributing factors to the symptoms, and additionally as a measure that could be monitored to assess how BPH progresses. Finally, serum creatinine or renal function is essential to know whether there is any effect of the prostate enlargement on the kidneys. On this slide, I'll talk in a little more detail about uroflowmetry. We perform uroflowmetry for a number of the patients that come to our clinic. It's a straightforward test to do, simply requires the man to have a reasonably full bladder and to pass more than ideally 150 mils of urine in order for us to interpret the flow rate. They pass the urine into a machine that measures the rate at which they're passing urine and produces a trace or a graph of the flow which can be interpreted. An example flow graph is demonstrated above. As you can see, I've highlighted that the Qmax, which is the peak flow rate measured in mils per second, is a very useful figure that you'll hear described by urologists to monitor or to comment on the effectiveness of a man's flow. Following the flow test, we tend to do a post-void residual bladder scan. This measures how much urine the person may or may not have left within their bladder. In other words, it's a measure of how effectively they actually empty their bladder. It's very simple to do, and we tend to do this at the bedside. It doesn't require a formal ultrasound scan. Now, BPH really needs to be considered as a progressive disease. As a man ages, they tend to notice symptoms more, the bother from the symptoms becomes more troublesome, the flow rate tends to decrease gradually, PSA and prostatic volume increase, and there is a chance additionally that the residual volume increases. As this progresses, it turns into an increasing risk of acute urinary retention, which can cause severe effects to the kidney function and may require urgent or emergency intervention. But how can we actually predict progression? There have been numerous studies reporting on the progressive nature of prostatic symptoms. In this particular paper, there was a note made of the link between prostatic volume, symptoms, and peak urinary flow rate as measures of progression of BPH. The Olmsted study described on this slide highlighted that flow rate tends to change with time. There was an approximate median deterioration of 2.1% per year, and in this study they noted that the deterioration would be more rapid if the man had an initially worse flow, in other words a Qmax of less than 10 mils per second, if they were older at the start of the study, or if their prostate volume was higher at the start of the study. Furthermore, other measures of the prostatic volume could include PSA that is rising, and that's been highlighted in numerous other studies. Therefore, it's worthwhile monitoring the PSA as you monitor symptoms. On this slide, you can see an image that depicts the function of the detrusor muscle in the process of bladder filling and bladder emptying. As the bladder is filling, the detrusor muscle is relaxed and the urethral sphincter and pelvic floor are contracted. However, once the person is ready to actually pass urine, the detrusor muscle contracts and the pelvic floor relaxes. This process is dysfunctional in men who have BPH, as the pelvic floor relaxing does not completely allow emptying of the bladder. This results in an increased pressure within the bladder and gradually developing detrusor weakness. As the person's BPH progresses, we tend to find that the risk of urinary retention increases. This is as a direct effect of the gradually increasing prostate volume and can be measured through the rising PSA and worsening symptoms, including overactive symptoms, which can be seen as a direct measure of the detrusor function. On this slide, I've shown you NICE recommendations. So NICE is the National Institute of Clinical Excellence based in the UK. It provides a kind of overview and guidelines to help manage common diseases. BPH is one of the diseases for which there is an easily located guideline, which you can find on the internet, and the link is at the bottom of this slide. So NICE recommends that in the first instance, if the symptoms of BPH or LUTS are not too bad, you might consider conservative management. If conservative management fails or if the BPH has progressed, the next step would be to consider drug treatment. For moderate to severe LUTS, we tend to offer an alpha blocker such as tamsulosin or doxazosin. For LUTS and a prostate volume estimated to be larger than 30 grams, or if the person has a PSA of 1.4, that suggests that they have a higher risk of progression. And for this situation, we would offer a 5-alpha reductase inhibitor. Some examples of that would include finasteride. For bothersome, moderate to severe LUTS, and for a prostate that's estimated to be larger than 30 grams, or if the PSA is greater than 1.4, we would offer a combination of the two, both an alpha blocker and a 5-alpha reductase inhibitor. Now I'll go into a little bit more detail about what these medications are. First is alpha blockers. These act by relaxing the smooth muscle within the prostate and the bladder neck. They have a rapid onset of effect. They tend to work within days, if not weeks. The Qmax can improve by up to 25%, and according to some studies and the European guidelines, the IPSS can improve by up to 40% on this medication. Alpha blockers are tolerated by most patients. The main side effects we warn people of are postural hypertension and retrograde ejaculation. Furthermore, when a person has come to hospital with urinary retention in the acute setting, for instance triggered by something like a urinary tract infection or constipation, we find that providing an alpha blocker can improve recovery from this. Unfortunately, some of the things against alpha blockers are that it makes no difference to prostate volume, and additionally it does not reduce overall long-term risk of acute urinary retention or the need for surgery. The next medication I mentioned is called 5-alpha reductase inhibitor. This blocks the pathway converting testosterone to dihydrotestosterone, and as a result of the androgen deprivation, it shrinks the prostate. On this medication, men find that their Qmax improves by 1.5 to 2 mils per second, and there can be a reduction in the prostatic volume, which results in a reduction in the risk of acute urinary retention and the need for surgery. It generally is well tolerated, however, there are side effects that we warn patients of, including impotence, ejaculation disorders, gynecomastia, and low libido. Unfortunately, on this medication, it does take quite a while for symptoms to improve, and the advice we tend to give in clinic is that the person needs to continuously be on this medication for up to 6 months in order for there to be a symptom improvement. There has been a great deal of research done into how to optimize medical treatment for BPH. 2 studies I'd like to highlight are the MTOP study and the COMBAT study. The MTOP study highlighted that combination therapy with both alpha blocker and 5-alpha reductase inhibitor could reduce the incidence of acute urinary retention. The COMBAT study compared individual treatments with combination therapy and found that there was a significant improvement in IPSS when using both an alpha blocker and a 5-alpha reductase inhibitor in combination. If medication fails, then the next step is surgery. There are numerous options, as highlighted on this table, which actually, as this guideline was written in 2010, is slightly out of date. However, rather than overcomplicating matters, I would simply like to highlight 3 of the main options that we would use to treat BPH through surgery. That is TURP, HOLEP, and prostatectomy, which would usually be done robotically in the UK, however in India tends to be done open. These pictures are to demonstrate how we would want the passage to look when sitting at the start of the prostate, which is a point known as the verumontanum. We would want to see directly into the bladder. So the aim of the operations described on the previous page is to open out the prostatic urethral channel to be able to gain an open passage from bladder to the urethra. On the previous slide and on this slide as well, you'll notice some of the landmarks that we search for to guide any bladder outflow obstruction surgery. At the bottom of the picture, you'll see a small raised lump. This is the verumontanum. The verumontanum is considered to be the start of the prostatic urethra. From a position at the start of the prostatic urethra, we want to look into the bladder, which is the black area in the distance, and be able to see clearly. With prostatic obstruction, there tends to be prostatic tissue blocking the way. So the aim of any bladder outflow obstruction surgery is to open out this channel. In other words, as titled on this slide, the aim of surgery is to provide effective and permanent relief of outflow obstruction. Going into a little more detail about the surgical options that I've highlighted, TURP or BNI is where we use a cauterizing loop, either using monopolar or bipolar energy to scrape away the transition zone of the prostate. I've included a small picture here of the process where we gradually try to clear a passage from the bladder neck right up to the verumontanum in order to clear the obstruction. And on the resectoscope, which is the equipment that you can see in the middle of the slide, there are different types of attachments we can use to help facilitate this. We can use a knife for bladder neck incision, a loop for TURP, and then the rollerball and the mushroom are both devices aimed at helping with coagulation. HoLEP is a more novel treatment, but is widely used. HoLEP stands for holmium laser enucleation of the prostate. The holmium laser is used to remove the transition zone entirely from the prostate. If you wanted to imagine it in a different way, it's as though you're removing the orange segments from the orange, but leaving the peel behind, as depicted in the picture. This is found to be a very effective treatment for BPH, and tends to be done for larger prostates, although can be done in any size of prostate. Finally, there is open prostatectomy. As you can see on this picture, it is a transvesical prostatectomy where the aim is to enucleate the transition zone in full, close the bladder over a catheter, and subsequently the patient will have better flow. Nowadays, we do tend to do this operation in the UK and in the US using robotic assistance. So, in summary, we've been through a lot of information today. We've defined BPH, BPE, and BPO, as well as low urinary tract symptoms, highlighting how you may measure this using a flow rate and the Qmax. The assessment of the patient should include all of the basics that you would do for any medical consultation, including history, examination, and then some of the more specialised scoring systems, including the IPSS. The risk factors for progression of BPH include initially quite bothersome low urinary tract symptoms, the larger prostate, a raised PSA, and a man being older. And then when describing treatments, it's important to remember that we should divide this or categorise this into three subsections: conservative options, medical options, and surgical options. Thank you very much for listening today. I'll be happy to receive any questions now or by email. Thanks.
If anybody does have any questions, please do send them in to +44 333 303 0975. We also really want your feedback on the presentations that we're giving you. There's a link on the YouTube chat, and there's also a QR code on the screen there. Please do send us your feedback. It really, really does help us. We'll be back in about 10 minutes with Dr. Sanjay Deshpande, who will be looking at the safety features of anaesthetic equipment and also human factors in medicine. But once again, please do send us your feedback and go get a coffee. As I said, please do send us your feedback. The QR code is on the screen right now. Give that a scan with your phone and send us your feedback. It'll take you to a Google Docs link, and there's a simple, straightforward questionnaire there for you. Your feedback really does help us. Please do fill it in. Also, if you're struggling with that, there is a link on the YouTube chat that you can use if you're at home. Once again, please do send us that feedback. We'll be back in about 10 minutes or so. Once again, just a plea for some feedback. Please do send us in the feedback using that QR code that's appearing on the screen. The link is also in the YouTube chat.
Hello, I'm going to give you a presentation on safety features on anesthetic machine. My name is Dr. Sanjay Deshpande from the UK. I'm just going to be very brief and fairly focus on the safety features. So modern anesthetic machines have improved greatly since 1917 when Boyle modified the American apparatus of 1912 to develop the ubiquitous continuous flow anesthetic machine. You can see an anesthetic machine at the background. Despite this, the basic principles and many components remain in modernized form. The gas is still supplied to the machine from a high pressure source, which is stepped down to a safe pressure supplying the breathing system. The flow meters control gas flows and allows for adjustment of different inspired concentration of gases. A vaporizer adds anesthetic vapor to the inspired gas, which is then delivered to the patient via a dedicated system. But modern improvements in safety, requirements for increased monitoring, and improved technology have driven changes in the anesthetic machine. Modern anesthetic workstations employ digital technology to deliver safe and measured anesthesia to patients. Despite improvements in safety and reliability, routine checking of anesthetic machines before use is essential. The Association of Anaesthetists of Great Britain and Ireland has developed a standardized checklist for users to ensure all components of the anesthetic machine are functioning appropriately. This slide shows the parts or the features in the anesthetic machine. It has a power supply, it has a gas supply, it has got the breathing system, it has a ventilator, it has got scavenging, it has got monitoring equipment attached, and also other features like a suction apparatus. So this basically shows the electrical supply to the anesthetic machine, and you can see all anesthetic machines are powered with electricity, and you can see the green light in the second picture, which demonstrates that the anesthetic machine is powered with electrical supply. The safety features, to start with, you remember the patient. There are probes which are specific on flexible hoses between terminal outlets and connection with the anesthetic machine. There is a pin index system to prevent incorrect attachment of gas cylinders to anesthetic machines. Flow restrictors on the upstream side of flow meters, and arrangement of the bank of flow meters. So oxygen on the left and nitrous oxide on the right. So this particular slide shows the Schrader wall. You can see the color probes. Oxygen is white, nitrous oxide is blue, air is black, suction is yellow, and you can see the anesthetic gas scavenging system, which has got a different sort of diameter and a different sort of configuration, which mounts into the wall. This particular slide shows the pin index system. You can see the yoke block, and you can see the cylinder wall. So if the oxygen cylinder fits onto the yoke block, it will sort of fit appropriately and avoid fitting another cylinder like nitrous oxide. So the pin index system is the safety feature on the anesthetic machine. To move on, there are non-return valves on the yoke block. So when one cylinder runs out, the presence of a non-return valve prevents empty cylinder being refilled by the cylinder which is filled. And also the non-return valve allows empty cylinder to be removed while the anesthetic machine is functional. There is an oxygen bypass valve which is beyond the vaporizer, and it ensures when it's pressed, it delivers emergency oxygen. The other component on the anesthetic machine is the vaporizers, which are on the back bar, and there are two Selectatec vaporizers control which permits only one to be in use at one time. And also this particular modern vaporizers, the vaporizers can be changed without interruption of the carrier gas to the patient. So this is the back of the anesthetic machine. You can see in the first picture the color probes which are delivering the high pressure to the anesthetic machine, and on the other side you can see the cylinders, the nitrous oxide cylinder which is blue color, and the oxygen which is a black body with a wide shoulder mounted on the yoke block against the pain index system. So there are pressure linked flow controls which is also called an hypoxic guard, and it switches off the supply of nitrous oxide automatically in the event of failure of oxygen supply. So when the oxygen fails, you cannot deliver any other gases. So that is a safety feature. There is a non-return valve situated downstream of the vaporizer, and that prevents back pressure, which may cause increased output of vapor. There is a relief valve which is situated downstream of the vaporizer, and it opens at 34 kilopascals to prevent damage to the flow meters or vaporizers if the outlet of the anesthetic machine gets obstructed. So these are the pictures of the rotameter block. You can see the oxygen knob, the nitrous oxide knob, the air knob, and they are also color coded. You can see the rotameter block, the oxygen on the left, air in the middle, and the nitrous oxide on the right. And you can also see the dial which allows what kind of mixture you want to implement when you're doing the anesthetic machine. To move on with the safety features, there is a pressure relief valve to set to blow off at a low pressure of 5 kilopascals, and that is fitted to prevent lung damage because of high pressure. As I mentioned earlier, there are oxygen failure warning devices, and it's an impending alarm, and it's a loud noise which basically indicates there is oxygen failure. The rubber bags which are in the anesthetic machine system or the green bags, they are also highly distensible, and it seldom allows the pressure to exceed 5 kilopascals. So these are certain pictures of the pressure gauges, and you can see the pressure gauges. It's about 400 kilopascals or 4 bars. You can see they are also color coded. Oxygen on the left, nitrous oxide is in the middle, and air on the right side. So you can see the modern anesthetic machines where you do not see the color probes or the color dials. You got one single main rotary control knob, and you can see on the screen the oxygen flow display, the agent concentration display, and you can also see the pipeline pressure display and the airflow display and the amount of oxygen which is available in the anesthetic gases. So you basically want to ensure there is minimum about 250 to 500 mLs per minute of oxygen delivered to the patient. These are the Selectatec vaporizers. You can see the sevoflurane vaporizer and the desflurane vaporizer. Those two vaporizers are configured in such a way that you can only operate one vaporizer at a time, and also you can also see that there are safety features built in that you can actually fill a vaporizer while an anesthetic is being administered. This picture shows the soda lime, which is meant for absorption of carbon dioxide, and obviously the closed circuit it basically provides efficiency and also maintains moisture, and you need to ensure that there is a good check of this closed circuit before you actually put it into practice for the patient. So we already talked about the hypoxic guards. Then also we talked about the vaporizers. There is a control knob. There is a locking mechanism. So once one vaporizer is in use, you cannot start the second vaporizer. And also there is a keyed filling mechanism available in those vaporizers. This is that oxygen flush, which administers oxygen at high flow in situations where you want to deliver 100% oxygen while administering the anesthetic. The rotameter block, we talked about that. So in a nutshell, I just felt that I should put up a slide illustrating all the safety features of anesthetic machine. You can see that there are non-interchangeable pipeline outlets. There are color-coded pipelines and cylinders. There is a pin index system. There are pressure gauges for anesthetic gases, or there are color-coded rotameters. There's an oxygen rotameter which is on the left, and it's ridged. Or there is an oxygen nitrous oxide interlink device. So there will be no delivery of nitrous oxide when oxygen fails. There is an emergency oxygen flush. There is an oxygen failure warning device. There are keyed vaporizers, fillers. There is a pressure relief valve. And basically you need to make sure that all anesthetists and the anesthetic ODPs check anesthetic machine before they start administering the anesthetic. I just wanted to show these slides stating that this particular safety guideline is available, which basically gives information about checking anesthetic equipment, and it is a requirement in the NHS that all anesthetic machines are checked before they are utilized for patient for delivering anesthetic to the patient. This is the checklist, and we have got copies of this checklist laminated on all anesthetic machines in their one in the operating theaters, and it basically gives you a sort of a aide memoire for ensuring the anesthetic machine is checked before you start the operating procedure. The two back tests to make sure that the closed circuit or has got no leak, and it basically talks about how to perform it, just that you do it prior to administering the anesthetic. And when you finish a case, before you check you need to have another quick check of the anesthetic machine before you start anesthetic for the second patient. So you check the breathing system, you check the ventilator, you check the airway equipment, and you check the suction before administering the anesthetic. So I just thought I'll show you a brief sort of picture of the anesthetic machine, the back of the anesthetic machine. You can see the cylinders and the probes which are actually mounted to the wall, the Schrader wall, the color-coded pipelines. So this particular picture illustrates all the safety features which are built in an anesthetic machine. This was my talk on the safety features of anesthetic machine. Thank you for listening. Hello, good afternoon. My name is Sanjay Deshpande. I'm going to give a talk on human factors in medicine. This is a topic which I'm quite passionate about. I personally have been practicing medicine for over 30 years, and I'm now convinced 100% that practicing technical skills plus non-technical skills enhances patient's outcome and enhances patient safety. So what are non-technical skills? Are communication, situational awareness, leadership, delegation, and task management.
The monkey business illusion. Count how many times the players wearing white pass the ball. The correct answer is 16 passes. Did you spot the gorilla? For people who haven't seen or heard about a video like this before, about half miss the gorilla. If you knew about the gorilla, you probably saw it. But did you notice the curtain changing color or the player on the black team leaving the game? Let's rewind and watch it again. Here comes the gorilla, and there goes a player, and the curtain is changing from red to gold. When you're looking for a gorilla, you often miss other unexpected events. And that's the monkey business illusion. Learn more about this illusion and the original gorilla experiment at theinvisiblegorilla.com.
My name is Martin Bromley. I'm dad to 2 young children, Victoria and Adam, and this is the story of the death of my wife, Elaine, who died in March 2005 as a result of an attempted routine operation that went wrong. There's some confusion about the precise time, but we know that 6 to 8 minutes in, a number of things were happening. The anaesthetist had already started to attempt to intubate Elaine. The oxygenation was still at 40% or lower, the heart rate was falling. The ENT surgeon waiting to perform the op came into the theatre. An anaesthetist from an adjoining theatre became aware of a commotion, and he walked in to see what could be done. And at least 3 nurses answered a call for help. And what happened is that the 3 consultants continued with the attempts to intubate, and they used a variety of different techniques and a variety of different pieces of equipment. The nurses, meanwhile, performed some tasks under their own initiative. But what we can say is that 10 minutes in, with hindsight, this is a situation of can't intubate, can't ventilate. This is a recognised emergency in anaesthesia for which guidelines exist. We're now 10 minutes into this attempted procedure. The patient, my wife, is blue. Her oxygenation is 40% or lower, and it has been for 6 minutes. The anaesthetist has 16 years experience, and he is regarded as diligent by his colleagues. The ENT surgeon has over 30 years experience. The other anaesthetist has additional skills pertaining to difficult airways, and 3 of the 4 nurses are all experienced in their job. And it's perhaps worth just wondering at this stage what was going through their mind. The intubation attempts had failed, the oxygenation was very low. What we know actually happened is this point in, 10 minutes for a further 15 minutes, the 3 consultants would appear to have continued with their attempts to intubate to the exclusion of any other option. And at the end of that 15 minutes, we're now 25 minutes into the whole procedure, they eventually get Elaine's oxygenation to 90%, but she's actually been at 40% or lower for a total now for over 20 minutes.
Keep going. Can we get above 90?
Nope, she won't go up.
No, you got 90 though, that's better.
I don't think we should carry on with the operation.
No, I agree, I think we should abandon it at this stage.
Okay.
The airway itself is not secure though, and so they fiddle around a bit more, and in fact her oxygenation falls again below 90% for a further 10 minutes, and finally by the time we're 35 minutes in, they seem to make the decision that the best thing is just to let her wake up naturally.
Let's wheel her back, quick as we can.
And they transfer her to the recovery room. She lays there for an hour and a half, and of course she never wakes up. Based on the evidence from the inquest and from Professor Harmer's report, the lead anaesthetist, if I can call him that, in his own words, lost control. There was a question mark in the inquest about who people felt was in charge at different points. There was certainly a loss of awareness, an awareness of time, but also an awareness of the seriousness of the situation. If you like, the awareness of what was happening wasn't shared by each of the consultants. There was certainly a breakdown in the decision-making processes, and it would appear that the communication processes dried up amongst the consultants. The story with the nurses is very different. The nurses were generally aware of what was happening and what needed to happen. When I said to you that 6 to 8 minutes in, those 3 nurses arrived, one of them asked her colleague to go and fetch the tracheostomy set. There was already a quick trachea kit in theatre. She went out, she collected the tracheostomy set, she came back in and she announced to the consultants that the tracheostomy set was available, and there was no response. One of the other nurses who walked in immediately saw Elaine's colour, immediately saw the vital signs, and walked out again to phone intensive care. She phoned to check that a bed was immediately available. She came back in and she announced to the 3 consultants that a bed was available in intensive care. And in her own words, they looked at her as if to say, "What's wrong? You're overreacting." She actually walked out and cancelled that bed. At the inquest, 2 of the 4 nurses stated that they knew exactly what needed to happen, but again, to quote from the inquest, didn't know how to broach the subject.
So I just have a sort of a layout of the learning outcomes. You obviously have seen the monkey illusion business, the importance of human factors, have a basic understanding of how errors occur and how to avoid. You obviously seen the story of Elaine Bromley. You probably could understand the concept of situational awareness, importance of effective communication and escalation, barriers to communication, describe an effective communication tool, and importance of multidisciplinary team. You have heard the word Latin phrase primum non nocere. That means first do no harm, and this was established by Florence Nightingale and mentioned in 1959 in the Notes on Hospitals. So the monkey illusion business, you obviously seen the video on the YouTube, and what it basically sort of explains is we are so focused on counting the basketball passes, You must have certainly missed the gorilla. You probably have also missed the curtain change, the color change of the curtain, and also the color of the first team leaving. This is called selection attention or selective attention. So why are human factors important? Human factors is to make it easier to do the right thing. So if it is easier to do the right thing, it will be harder to do the wrong thing. You have definitely heard the phrase, to err is human. That is, human error is in human nature. We make silly mistakes all the time. I have done errors at home, so has you, but it does not very often lead to serious consequences. Example like forgetting a key in the house, or when you go into a supermarket, you pick up a wrong item in the supermarket. So it doesn't really lead to any consequences. The other example is making a cup of tea at somebody's house. It's not that you are not able to make a cup of tea, but you are working in an unfamiliar environment, and that can lead to an error. So the same principles of human factors apply in medicine. So the science of human factors explains why we make mistakes and how we can design a workplace to minimize mistakes. The concept of human factors explains how we interact with each other in workplace, how we interact with the physical environment, how we interact with the equipment, and how we interact with the processes of care. It is very important to understand the culture of the organization, what happens when mistakes happen in the culture, and how human beings sort of interact. So understanding of human factors will help to understand why errors occur, and it also helps to enhance patient safety. To err is human, and I basically explained that in the previous slide. What I wanted to show you is human factors. The terminology came from aviation industry. You obviously heard the YouTube Just a Routine Operation, and that was presented by Michael Bromley. He's an airline pilot, and he explains the importance of human factors. Human factors play a very important role when in aviation industry, and that's where we actually embrace the term in medicine. So we all go to hospital, and we don't really come to hospital to harm any patients. One of the human factor model, which is increasingly well known, is the Swiss cheese model, and that was described by James Reason. Each layer of cheese, if you look at that picture, represents a barrier and it acts as a level of defense. Unfortunately, no barrier is perfect, and that represents as a hole in the cheese. So when all the holes in the cheese layers, they line up, that's when errors occur. So it's quite important to look at an error like an error chain, because the holes will align, and then that's when all the safety features are sort of superseded and mistakes happen, and it can lead to patient harm. Situational awareness is a terminology which you have heard on the YouTube video of Martin Bromley. It's knowing what is going on around you. So it's quite important to have a good situational awareness at all times. not to get stuck to one task. If someone notices something, it's quite important for that particular person amongst the team members to speak up and flag up, even though that particular point may not be relevant or may not be important for that particular person, but it could turn out to be important for the patient care. Senior staff should have the ability to listen to concerns, so they should not really they should work as a constructive team, and obviously listen to all the staff's concern. What are the warning signs of loss of situational awareness? When there is confusion, when there is uncertainty about next action, that's when we have lost the situational awareness. So the most important is to try and go back, start again, and discuss the scenario with a colleague. Just an example of ABCDE. So if you basically practicing ABCDE and you just got lost of track at one particular point, then just go back to ABCDE. That way you ensure that you are delivering a good care to the patient. So it's quite important to be aware of the environment at the time of an incident and analyzing and understanding how individuals' actions may impact on future events. So it's quite important, the concept of situational awareness, where many events are happening. Particularly an example is cardiac arrest. So in summary, the situational awareness consists of information gathering, assimilation of information, interpretation of information, and action planning. So you obviously have seen the story of Elaine Bromley. This was presented by her husband in the YouTube, and on the heading "Just a Routine Operation." The issues that were flagged up with Elaine Bromley were loss of situational awareness, which you probably have made out after looking at the video, lack of knowledge or lack of perception and cognition, because they did not really practice the Difficult Airway Society guidelines. You obviously saw there was no team leader, so there was a poor functioning team, and also there was issue with the culture. The nurses in the background were trying to flag up, and they even brought this tracheostomy kit, which could have saved the patient's life. So if you look at this particular slide, there is 1 in 300 chance of accidental death through errors in care. More than 1 in 10 people admitted to hospital are harmed unintentionally by its care. The media, you must have seen news in the media, how things are portrayed, particularly if accidents happen, patients die, and how doctors are have to face charges, and it is quite a scary sort of situation. So it's quite important to practice good human factors in order to avoid patient incidents. So the non-technical skills which I was talking about are cognitive skills, social skills, and interpersonal skills, which contribute to safe and efficient task performance. So what are the examples of poor non-technical skills? One is unwillingness to help. Second is poor communication. Third is poor leadership skills. Fourth is poor decision making, and no clear roles allocated to staff when they are actually facing or dealing with an emergency. So what are the non-technical skills which I've already mentioned earlier? Is communication skills, situational awareness, team working, decision making, and delegation. So how we implement human factors in our clinical environment. So the points which are important, or the is number one is to avoid reliance on memory. Second, make things visible. Third is review and simplify processes. Fourth is standardize common processes and procedures. Fifth is routine use of checklists. And sixth is decrease reliance on vigilance. So you obviously now got the slide which basically flags up all the recent sepsis tool, for example, the sepsis 6, which Johnny mentioned to you in the last talk. Is so if these particular screening tools are available, so that you do not have to rely on your memory. So you basically try and practice this particular way to avoid relying on your memory. The second is to make things visible, so points on the ward information, information on the board, safety briefings, so that way it becomes obvious to all staff about things which are happening in the hospital. Reviewing and simplifying processes. An example is S-bar. The S stands for situation, B stands for background, A stands for assessment, which is A, B, C, D, E, and R stands for recommendation. Fourth is standardize common processes and procedures, and the example is the News 2 score, which basically gives you points depending upon which parameter gets affected, and that gives you a score which then triggers a response. And the routine checklist, one of the things which we are practicing now is the WHO checklist, and that basically flags up any issues and ensures patient safety all the time. Decrease reliance on vigilance. So if you look at those bottles which are color they're basically designed in the same sort of shape and same color. So it's important that you read the bottles. We had incidents with acetone and sodium citrate, and I've heard at times where patients have been given acetone instead of sodium citrate as an antacid. So these errors do happen because the shape of the bottle, the color of the bottle look similar. So that's important, is to rely on vigilance. One other thing which is quite important is simulation. So those who work together should train together, and the ability to acquire skills through deliberate practice. This helps to bridge the gap between theory and practice. So organizations like the National Health Service have systems in place called National Reporting and Learning System. They actually collect incidents and review those incidents. In 2019, there were 2 million incidents reported to the National Reporting and Learning System. Majority of these incidents did not cause any harm, but about 12,000 incidents per year have led to serious harm or even death. And in this particular sort of report, it was suggested that human factors were responsible for 60 to 80% of the incidents. The Care Quality Commission actually stresses a lot of importance to human factors, because by understanding the science of human factors, we actually can focus on patient safety and change behaviors of human beings in order to reduce the errors. So what are the aims of effective communication? The aim is to convey the appropriate information to achieve the right treatment to the right patient at the right time and by the right person. So what are the barriers to communication? The barriers are language, culture, age, sex, pain, fear, trust, stress, anger, sensory impairment, visual impairment, noise, drugs, time. Hierarchy is one of the important factors, seniority, ranking, jargon, tone of the body, tone of the voice, and body language. So these are very important factors which contribute to barriers to communication. So what is the impact of ineffective communication? Patient not assessed, patient not managed in a timely manner, and that will lead to delay in patient's treatment. It can lead to incorrect or inappropriate treatment, care not prioritized, and increasing clinical risk. So this is the acronym called PACE. It has been found out that speaking up during an emergency is quite hard. There was a medical student in 2005 who knew about a kidney operation and which side kidney was going to be removed. The rest of the team were knowledgeable because of the way the patient was positioned in the left lateral position, that particular team took the wrong kidney out. So amongst the team members which were present in the operating theatre, it was only the medical student who knew that they were taking the wrong kidney out. If the medical student could have spoken about it, or you could have expressed concern, that patient's right kidney could have been removed. So in order to actually speak up, this is the acronym which has been suggested in critical care and in the NHS. The P stands for probe, A stands for alert, C stands for challenge, E stands for emergency. And the example is, if you patients notice that the blood pressure is dropping on the monitor, you could probably say, oh, I just noticed that the patient's blood pressure is below, or MAP is below 60. If nothing is happening, then you could probably then say, oh, I think something is going to badly happen to this particular patient. Then if nobody is actually taking notice of what you're telling, then you could challenge. And then if, in spite of challenging, if nothing is happening, then you could say, I'm going to get the sister or I'm going to get the consultant to look after this patient. So that way, that person who is in the team could actually speak up. So the whole culture is to try and have a flat sort of hierarchy, so that everybody in the team has got the ability to speak and express concern. This is the communication tool which we practice in our hospital called SBAR. S stands for situation, B stands for background, A stands for assessment, and R stands for recommendation. And I've got a video which you probably will be seeing at the end, which clearly demonstrate how important the communication is when you are actually conveying information about a patient to your senior. So this is the video which you will be seeing shortly, and that will illustrate the importance of communication skills and using the SBAR approach.
Hi, Mr. Jones. It's Jane calling from Ward 4. It's about your patient, Mr. Smith. He's 4 days post-op and he's not very well this evening. Oh, you want his obs? 1 minute.
SBAR, or Situation, Background, Assessment and Recommendation, is a structured method for communicating critical information to colleagues. Begin by identifying yourself, where you are calling from, the patient's details and the reason you're calling. Describe your concern to your senior colleague.
Good evening, Mr. Jones. It's Jane, one of the SHOs that's on call this evening. I'm calling from Ward 4 about a patient called Stephen Smith. Yeah, he's a 45-year-old gentleman, 5 days post-lap chole. Looking at the op note, it looks like it was quite a difficult procedure that was converted to open due to a difficult dissection around the bile duct. I've reviewed him as he's had an increased abdominal pain over the last couple of days, and this hasn't really settled with increasing amounts of opiate analgesia.
Give the date and reason for admission, any procedure since then, any relevant medications, and any past medical history.
Well, he was admitted to the ward 5 days ago after his surgery. He's normally fit and well, doesn't take any regular medications, and doesn't have any allergies. Since he's been with us, he's had some regular simple analgesia such as paracetamol, and also this evening increased in amounts of morphine. He's on day 5 of a course of oral coamoxiclav. Looking at his bloods, his white cells and CRP are showing an upward trend over the past 3 days.
Inform your senior of the patient's current vital signs and your clinical impression. Highlight the main concerns you have about the patient.
He's febrile with a temperature of 38.8 and tachycardic with a heart rate of 135. His blood pressure is maintained at the moment. On examination, he's cool peripherally and his urine output has been reduced. His abdomen is soft and very tender, especially in the right upper quadrant. His wounds look clean and dry. I'm concerned that the patient might have a bile leak or a collection developing.
Explain what you need from your senior, making sure you're specific about your request and the time frame. Suggest a management plan and clarify this with the person you're speaking to.
I think this patient really needs an urgent senior review as soon as possible. Would appreciate if you'd be able to come down and see him. In the meantime, I'll give him a fluid bolus and send off some urgent bloods. Is there anything else you'd like me to organise?
The SBAR tool is a structure that enables good communication of critical information requiring immediate attention. This is essential for the safe delivery of care to our patients.
So what are the causes of error? One is lack of knowledge. Second is lack of training, limited resources, mental workload, distractions, slips and lapses, physical demands, and fatigue, stress, lack of sleep, hunger. Obviously, these are the various reasons why errors happen. So, in summary, I try to explain the role of human factors. We are all human beings. We all make errors. And it's important that we understand the concept of human factors, how we interact with each other, how we interact with the environment, how we interact with the equipment, and how we interact with the processes. Thank you very much.
Once again, please do send us your feedback. That QR code is on the screen now. Your feedback really does help us. That's the end of the week's teaching. Thank you very much to everybody, all our speakers who've put in their own time and effort into making these presentations. Thank you very much to all of you for listening and taking part. Thank you for your feedback. If you do have any feedback for us, please do leave it in the there's a link in the YouTube chat there. You can also view our Facebook page, www.facebook.com/SVJCUK, where you'll be able to find all the videos that have been played. There's links to them on YouTube there. But for now, thank you very much all for all your efforts this week, and we hope to see you next year.